Hello everyone, welcome to the 5th module for the course Prevention and Rehabilitation of Complex Chronic Conditions. This module is titled Self-Management and Rehabilitation. In today's lecture, we'll talk about why the concept of self-management is important. We'll define self-management in itself as well as self-management support. We'll talk about self-efficacy. We'll review how self-management support is put into practice. Then we'll look at the term rehabilitation and different rehabilitation settings and the professions involved. Let's begin by discussing why self-management is important. As we have discussed in the recent past, the prevalence of chronic conditions has been steadily rising over the years to the point where some researchers claim that chronic conditions will overwhelm the medical and personal resources of countries like Canada, and this is due to the aging population and rising healthcare costs. This increase in prevalence of chronic conditions is altering the way in which care is delivered and in the way that it is being received. People are and will continue to live for a long period of time with chronic conditions, and this occurs mostly outside of the formal healthcare system. Clinicians are really only present for a fraction of a patient's life. In the past, almost all healthcare and teaching was provided by healthcare professionals, but now there's acknowledgement that many of the clinical functions, so for example, monitoring hemoglobin A1C, blood pressure, weight, and teaching activities can be effectively carried out by the patients themselves. An inherent philosophical reorientation is taking place whereby health professionals are seeing their relationship with patients is changing to one where they are seen more as a partner or as a coach in the process. A person's behavior towards their chronic disease has a very large impact on the progression of the disease, and by engaging a person with a chronic condition to participate in the healthcare process through self-management, the hope is that this will improve health outcomes and reduce cost. There is no universally accepted definition for self-management. There are many different terms used to describe self-management, and the terms used in the different definitions describe the attributes, roles, and responsibilities that are shared to varying degrees by both people with chronic health conditions and healthcare providers. Here I provide a list of different perspectives that have been applied to self-management. Self-management can be to comply or adhere to medical treatments, and this implies a medical orientation towards self-management. An example would be whether or not you adhere to your medical doctor's recommendation to quit smoking, to help with an existing heart condition, or even just to take medication for arthritis as prescribed. Self-management can also mean to have a personal belief that one is capable of following treatment regimens. So having a personal belief addresses the psychological aspects of self-management. If you don't believe you can monitor your own blood sugars, then you're less likely to be able to do so. Having a person believe and be able to follow treatment is often discussed in terms of self-efficacy, which we'll talk about later. Self-management can mean having the functional ability to carry out activities independently. The goal of self-management is for the patient with chronic disease to be able to carry out activities of daily life. Remember that activities of daily life is a term used in rehabilitation, really as an umbrella term relating to self-care, comprising those activities or tasks that people undertake routinely in their everyday life. For example, walking, feeding, toileting, dressing, cooking, managing money even. The last perspective on self-management is that it can mean to self-determine how to meet one's unique needs. Self-management should include components that look at how a patient actually cares for themselves, and self-management should be client-centered and understand the unique needs of individuals. A patient, for example, might have different health or activity of daily life priorities in comparison to that of the healthcare provider. Each of these perspectives has been researched, and there's evidence that supports interventions based on these concepts. Definitions should therefore include each of these characteristics. The terms imply varying specification regarding attributes, roles, and responsibilities of both people with chronic health conditions and the healthcare provider, which I mentioned at the start of this slide. This definition envisions self-management as behaviors, but includes the notion of confidence and embraces clinical management as well as role and emotional management by the individual. This definition of self-management provides clarity in that it focuses on the person with the chronic condition and further introduces the concept of self-management support, which specifies what healthcare providers can do in order to encourage self-management. On this slide, I am providing you with a definition of self-management that has been put forward by the authors Adam Grenier and Corrigan in 2005. This definition is supported both by the group of writers that produced the OPMEC publication, and it's also supported by the Registered Nurses Association of Ontario, who in 2010 produced best practice guidelines focusing on strategies to support self-management. The first part of the definition of self-management is the tasks that individuals must undertake to live well with one or more chronic conditions. This part is useful because, as you know, many people live with more than one chronic condition. The second part of this definition states that these tasks include having the confidence to deal with medical management, role management, and emotional management of their conditions. In parentheses, I'm only showing you that the OPMEC text uses slightly different words. This definition conceptualizes self-management as behaviors or tasks, but it also includes the notion of confidence and embraces clinical management as an important component. This definition addresses the 3 tasks that people with chronic disease need to address. They need to manage the medical aspects of the condition. So, for example, someone who is overweight with diabetes needs to take their medication, change their diet, self-monitor blood sugar, etc. Secondly, a person with a chronic disease needs to manage the way they accomplish activities of daily life, including work, personal care, recreation. And thirdly, they need to cope with the emotional aspects of having a chronic disease, including, possibly, anger, fear, frustration, and sadness. On the previous slide, I spoke to you about self-management. On this slide, I'm providing you with the definition for self-management support, which is a slightly different concept. According to the Registered Nurses Association of Ontario, clients require support in order to obtain the education, skills, and confidence required to effectively manage their condition. Healthcare providers utilize a variety of techniques and strategies to offer this support. Specifically, self-management support is defined as the systematic provision of education and supportive interventions by healthcare staff to increase patients' skills and confidence in managing their health problems, including regular assessment of progress and problems, goal setting, and problem-solving support. We will go into some additional detail with respect to some of these strategies, the strategies that are introduced in this definition. But to differentiate a little more between what self-management and self-management support is, think of self-management as encompassing problem-solving skills and patients' collaboration involvement in establishing goals to manage their disease. Self-management support, on the other hand, consists of the means by which individual practitioners and the broader healthcare system support patients in trying to exercise self-management. This definition of self-management support is consistent with the information that we spoke about during the module that dealt with models of chronic care, and you should recall that self-management support was one of the key components of the healthcare system as described in the chronic care model. You have now learned that self-management support includes educational interventions. On this slide, I'm presenting to you the distinction that the OPMEC text makes between traditional patient education and education as it is applied during self-management support. Traditional patient education involves the mostly didactic instruction given to patients, focusing on disease-specific information and technical skills. An example of this is a diabetes educator lecturing to a group of diabetics about the disease process and then teaching them how to self-inject insulin or to monitor their glucose levels. Traditional patient education is based on the underlying theory that disease-specific knowledge leads to behavioral change, which in turn produces better health outcomes. The goal with traditional patient education is patient compliance with the instructions that are given. In contrast to traditional patient education is education that is delivered in the context of self-management support. The focus of education in this context is to teach clients skills that they can use to self-identify problems relating to living with a chronic disease, and skills on how to address those problems. In this situation, the problem-solving skills can be applied to a broad number of situations. Self-management education, meanwhile, is based on the theory that greater patient confidence in his or her capacity to make life-improving changes yields better clinical outcomes. And the goal in education as delivered in self-management support is to increase self-efficacy and improve clinical outcomes. In the end, both of these approaches are needed in order to achieve high level of quality of life and independence in people with these chronic diseases. You should consider education as practiced in self-management support as complementing rather than substituting for traditional patient education. According to the Open Mic chapter on patient education and self-management, education for patients with chronic health conditions should include the following components. The first component is disease-specific education. The second component is managing skills, the skills that help patients deal independently with the problems that might develop. For example, developing skills like problem solving and goal setting, learning how to find and use health and social services. The third component in education for patients with chronic illness includes strategies that increase patients' confidence, also known as self-efficacy. So confidence in their ability to deal with the sequelae of their condition on a daily basis. The fourth component includes adequate peer role models and support networks made available to the people with chronic diseases that help in the initiation and the maintenance of the desired behavioral changes. In my view, these aspects of patient education are important for improved patient outcomes, but I think the benefits of using each of these independently or even a combination of these approaches is dependent on the circumstance. For example, someone with a severe condition and in a more complex social situation might need all of these strategies, whereas someone living with a less severe condition with a supportive environment may need only one or two of these strategies to deal with their chronic disease. The term self-efficacy has come up several times during this presentation. The concept was first described by Bandura in 1977 and is defined as the belief in one's capabilities to organize and execute the course of action required to produce a given attainment. More briefly, it can be described as the confidence in one's ability to achieve a behavior. A strong sense of self-efficacy has been shown to have a positive influence on achieving health-promoting behaviors in people with a chronic disease. Self-efficacy has been positively associated with better health status outcomes in a range of conditions relevant to rehabilitation. An example of this is a study in 2008 by Model and Snook. Among people with multiple sclerosis, the study showed that greater self-efficacy beliefs in function and control were associated with being more physically active, and were positively associated with greater physiological and psychological components of quality of life. Guided mastery, which is a process of developing long and short-term goals, has been shown to be an effective way in raising self-efficacy. Individuals' willingness and ability to change behaviors depends on their self-efficacy and on their circumstances. Building self-efficacy skills is therefore important, but so is changing individuals' circumstances in which they live. According to the chronic disease framework developed by the Ministry of Health and Long-Term Care, healthy living is difficult in neighborhoods without sidewalks, or without stores selling nutritious foods, or for individuals who cannot afford to buy nutritious food. Again, from the Ministry of Health and Long-Term Care, in order to change health behaviors population-wide, personal skill building needs to be a part of the broader health promotion strategy, addressing all of the determinants of health. In 2010, the Registered Nurses Association of Ontario produced best practice guidelines that looked at the strategies to support self-management. In the guidelines, the RNAO encouraged the use of the 5 A's of behavioral change, which embodies the principles and strategies to successfully deliver behavioral risk factor interventions, provides a unifying conceptual framework for supporting self-management. It was first proposed by Glasgow in 2002. The 5 A's are assess, advise, agree, assist, and arrange. The 5 A's represent a comprehensive set of activities that healthcare providers can use as they're supporting their patients with chronic diseases who are in themselves trying to engage in self-management. These activities are not necessarily linear, with each step following the other sequentially. The goal of the 5 A's in the context of self-management support is to develop a personalized, collaborative action plan between the patient and the healthcare provider. That includes specific behavioral goals and a specific plan for overcoming barriers and reaching these goals. The figure on this slide outlines the 5 A's. It is the figure that was used in the RNAO's self-management guidelines. The goal of the 5 A's, as you can see in this figure, is in the middle. The goal is to produce an action plan that is informed by including all of the elements of the 5 A's. The first item in the 5 A's is assess. During the assessment step, it is important that the healthcare provider takes the time to establish trust and rapport with the patient. It is important to ensure that patients have opportunities to express priority concerns. For this activity, the healthcare provider may collaboratively set a visit agenda to make sure that concerns are addressed during the visit, gather health behavior info, assess the patient's readiness to make a change, and tailoring the discussion according to the degree of change. In the RNAO's self-management guidelines, nurses are encouraged to screen for depression on the initial assessment and at regular intervals after that, and advocate for follow-up treatment of depression when it's identified. Major depression is a major health concern commonly seen in those with chronic diseases. The second A is advise, and it states that a healthcare provider should provide specific information about health risks and benefits of change to a person with a chronic disease. This is where all the information already presented in this lecture on patient education is most applicable. RNAO recommends that healthcare providers combine behavioral strategies, psychosocial strategies, traditional patient education, and self-management education approaches in order to deliver effective self-management support. It is also recommended to use the closing the loop technique when giving health information to a patient. This is a communication technique where the patient is asked to repeat in their own words the information given to them. It is a useful way to assess a patient's level of understanding of the info given and to identify areas that need to be clarified. Lastly, it is recommended that healthcare providers support clients to effectively self-monitor their condition. For example, advice might include self-monitoring techniques for glucose or blood pressure and methods to keep track of the health condition. This could be diaries or logs. The third A is agree. This is where the healthcare provider collaborates with the patient to establish goals for self-management, develop an action plan that enables achievement of goals, and monitor progress towards goals. Although all of the activities, or the 5 A's, contribute to the creation of a personal action plan, it is in the third step that the initiation of developing an action plan is really put into place. An action plan is an agreement between the healthcare provider and the patient to help patients work towards behavior change. And recall that the purpose of the action plan is to increase self-efficacy, the confidence that the client can change something. I should stress that both the setting of goals and the development of an action plan should be done collaboratively, and it is important that the steps that are involved in the agree activity are done with the patient's interest in mind, and that their willingness to change a specific behavior is taken into account. Without doing this, there is less of a chance that the behavior will actually be changed. A standard question asked by the healthcare provider is there anything you would like to do this week to improve your health? The fourth A is assist. In this strategy, the healthcare provider is encouraged to identify the client's personal barriers to change, to teach and assist the client about problem-solving techniques, and provide the client with access to community self-management programs. Motivational interviewing is an example of a strategy used to facilitate behavioral change by exploring the patient's ambivalence to change. The effect is to reduce defensiveness and encourage engagement, thereby increasing the motivation to make a behavioral change. This is a client-centered approach that does not try to coerce a patient to change. Motivational interviewing is an advanced skill that requires training and practice. The assist stage includes problem solving, and the ability to problem solve is really a core self-management skill. It is important that the healthcare provider helps patients with chronic diseases acquire the skills necessary for effective problem solving. The process usually involves defining the problem, generating possible solutions, implementing the solution, and then, of course, evaluating the results. Lastly, another component of the assist stage is to provide social and environmental support. Healthcare providers can inform clients about community self-management programs. They can tell clients about existing community resources such as self-help and support groups. The fifth and last component of the 5 A's is arrange. This is where the plan for follow-up is specified. The way that follow-up is arranged should use the most appropriate approach. For instance, it could be a face-to-face visit, a phone call, or through teleconference. Follow-up provides ongoing assistance and support to the patient with chronic disease. It provides the opportunity for adjustment of the treatment plan or action plan as needed, and it includes referral to more intensive or specialized treatment whenever it's warranted. Health professionals who are involved in the rehabilitation of individuals who experience disability commonly use self-management support strategies in their day-to-day work. On this slide, I present to you the definition of rehabilitation proposed by Stuckey et al. In 2007. This definition is based on the concepts from the World Health Organization ICF, which stands for International Classification of Functioning, Disability, and Health. The ICF provides the most recent and comprehensive model of functioning and disability. The ICF was produced or approved by the World Health Organization Assembly in 2001. It is a universally and globally accepted model and taxonomy of human functioning and disability. Since the primary goal of rehab is to enable people to achieve optimal function and mitigate the effect of disability, it makes sense to frame a definition of rehabilitation around this model. According to Stuckey et al., rehab from a public health perspective can be classified into one of a few different strategies. One health strategy is the curative health strategy, and the other is the preventative health strategy. And the key outcome for both of these is survival. For example, wanting to cure someone with tuberculosis or prevent a population from ever getting it. In the rehabilitation strategy, the key outcome is not to cure, but rather to maximize functioning and the quality of life of someone who is living with disease. I'll let you read this lengthy definition on rehabilitation on your own, but I'd like to highlight some important terminology used within it. The first part of the definition states that rehabilitation is the health strategy applied by health professionals. The most well-known professionals are those that are trained at rehabilitation schools. These are professionals who, by definition, are involved in rehab in most of its incarnations. There are specialties in medicine called physical and rehabilitation medicine. They are referred to as physiatrists. There are nurses as well that can be specially trained in the area of rehabilitation. I'm only naming a few, but these are ones that are well known. Another part of the definition states that rehabilitation takes place in the health sector and across other sectors. The health sector can therefore be considered the reference, the root, or the anchor sector where rehabilitation takes place. However, rehabilitation is also a truly multi-sectoral strategy. In many situations, for example, in the rehabilitation of children with special needs, services and care are primarily provided by the educational sector rather than by the health sector. Another example is vocational rehabilitation. This is oftentimes provided and or paid for by the labor or social sector. The aim of rehabilitation is to enable people with health conditions experiencing or likely to experience disability to achieve and maintain optimal functioning in interaction with the environment. You're not just looking to enable change with the person, but also through adapting and modifying the environment that the person lives in, including housing, assistive devices, family, peers, employers, etc. Rehabilitation strives to reverse what has been called the disabling process and may therefore be called the enabling process. This definition uses the term experiencing disability versus saying with disability, which could imply an attribute of the person. Saying experiencing disability suggests that it's not just the capacity of the person that rehab addresses, but also environmental issues. The last comment on this slide is with respect to remediation versus compensation. When a person with a disability presents to a rehabilitation therapist, the rehabilitation first attempts to remediate the person's disability. For example, if a person has weakness in their leg due to arthritis, the goal would be to try and strengthen the leg. Now, if the weakness does not improve, then the therapist may try to compensate for the problem by providing a gait aid. The term rehabilitation is used by different fields, including engineers and laborers who will talk about rehabilitation of roads and other infrastructure. In healthcare context, you will also hear about rehab for people with addiction problems. There are geriatric rehab programs that provide functional rehabilitative care to the medically complex, frail elderly who have experienced a decline in function. This would include, for example, someone with multiple comorbidities who no longer can live at home alone, and maybe they've recently sustained a fracture of the hip. There are also pediatric centres across Ontario, such as Grandview Children's Centre in Durham Region. These centres provide rehabilitation for children with various physical and behavioural problems, for example, autism, cerebral palsy, but then other conditions such as speech therapy or improvements in fine motor skills. And lastly, there are rehab programs that exist at hospitals. In all of these settings, at least some of the principles of self-management support are applied, or at least they should be applied. On this slide, I wanted to share with you an assessment that is very commonly used in the rehabilitation world. This is called a Functional Independent Measure Instrument. It is used to evaluate the severity of disability of people with conditions such as a stroke. The functional ability of a person with a condition like a stroke changes over time, and the FIM instrument is used to track those changes. The FIM instrument comprises 18 items, and they are categorized into self-care, sphincter control, transfers, locomotion, communication, and social cognition. Each one of these items can be evaluated using a 7-point scale, which we can see here at the top. So a rating of 1 means that a person with a disability needs total assistance, and somebody with a 7 is completely independent with the item that you are rating. Once you've evaluated each one of these items in a given individual, you are supposed to then add up all of the scores. The range in scores is between 18, which is the lowest score that you can have. So that would be somebody who's extremely dependent on other people for all of their needs, and it can go up to as high as 126. And that would be a score for somebody who has become completely independent in their abilities in each one of these items. The FIM can be applied to a person with a disability in 3 different time periods. For instance, in this situation, the FIM is scored at admission, at discharge, and at follow-up. And you can see how it becomes important to use the FIM to support how somebody has changed over time while they're getting rehabilitated. The other thing I wanted to mention and to make a comment about is that each one of these categories is usually evaluated by a separate rehabilitation profession. So, for example, self-care could be evaluated by an occupational therapist. The items for sphincter control, including bladder management and bowel management, is frequently evaluated by a nurse. Transfers, bed, chair and wheelchair, toilet, tub, shower transfers, commonly done by a physiotherapist, as is locomotion. The communication item is evaluated usually by a speech-language pathologist. And the social cognition items are frequently done by either an occupational therapist or a psychologist. That is the end of today's presentation on self-management and rehabilitation. Thank you for listening.